All right. Good morning, everyone. It's 7 o'clock. Hopefully, everybody can hear me. I have the pleasure of introducing Dr. Ali Tavasoli today, who's going to be presenting to us. He is our headache medicine fellow here at Phoenix Children's, and it's been excellent working with him. He's going to be speaking to us on navigating the complexities of migraine pathophysiology. Thank you very much, Dr. Tavasoli. You can go ahead and start.
Thank you so much for your introducing, Dr. Luis. Good morning, and I'm very happy to be here, and hopefully you enjoy your these rainy days. So my topic for today is navigating the complexities of migraine pathophysiology. And next slide. Does it work? All right, here we go. So this is my learning objectives. At the conclusion of this study, we will learn something related to migraine incidence, and then I will talk about different clinical states of the migraine, and then we will describe the anatomical network and the chemical pathways involved in different clinical stage of the migraine. And during this talk, I will not cover these topics, so the genetic details and the clinical aspects of this clinical stage of the migraine. These topics will not be covered. And then during this talk, we will learn about noun and unknown aspects of this stage. And at the end, we will talk about a little bit about the future perspective and understanding of migraine and its treatment. So this is the report of the Global Burden Disease Project, which was published in last year for migraine, and this data was gathered between 1990 and 2019, so over the last 3 decades, from 204 countries, and this data was analyzed both globally and based on the Social Demographic Index, which is in brief SDI, across different countries, and the results published in the Journal of Headache and Pain. So this is a diagram mapping the incidence of the new migraineurs all over the world, and you see here at the national level, India, China, United States, Indonesia are the most top 4 countries that they have the new migraineurs over the last 3 decades, which is very interesting. So it is at least 44% of the new migraineurs over the last 3 decades. And if you look at the position of the United States, which is the high SDI country, you will see here the position of the United States, which is close to the bottom of this map. So the next slide is showing distribution of the new migraineurs across different age groups, across different SDI countries, And if you look at the map here, this is the analysis of the data globally, so all over the world. And this is my diagram of interest, which is the United States standing here between countries with high SDI. If you look at the data here, you will see different tapes here showing different age groups, and the most part of this diagram is belong to the age of 10 to 14. So it means that both globally and between the countries with high SDI, the highest incidence of the new migraineurs happen in the age between 10 and 14. So we have a lot of new migraineurs in the teenage, both globally and in the United States as well. So the next part of my lecture is different clinical states of the migraine. And in this diagram, you will see in brief 4 main clinical stages of migraine. The first part or the first stage is called premonitory phase or prodromal phase. The second one is the oral, the next is the headache one, and the last one is the postdromal phase. So based on the timeline, you see here that they have overlap and there is no clear cut between these clinical states. So 30% of all migraineurs have all these 3-4 stages, which is called migraine with aura. In 70% of the migraineurs, they don't have the aura phase. So they have the premonitory, the headache phase, and the post-traumal, which is called migraine without aura. However, a small percentage of the migraine, again, they have 3 stages, but without the headache, so lack of the headache. And imagine if a patient comes to you and present with the aura phase and then the post-traumal, definitely you will think of cerebrovascular attack because the patient is not suffering from the headache. And we are focused on any etiology resulting in focal neurologic deficit in this small part of migraineurs. So before I talk about the clinical stages of the migraine, I would like to do a brief review on the anatomy of the cranial nerve trigeminal, because this is the most important cranial nerve involved in the pathophysiology of the migraine. So in this diagram, you will see the main 3 branches of the trigeminal nerve. So the first one is the ophthalmic, the second one is the maxillary, and the third one is the mandibular. And in this diagram on the left side, you see the sensory and the motor distribution of these 3 nerves. And the ophthalmic one is the most important branch. We need that to explain the pathophysiology of the migraine. So the first branch, which is the ophthalmic, is a sensory nerve. The second one, the maxillary, is a sensory nerve once again. However, the mandibular, which is the last branch of the trigeminal nerve, is a combination of the sensory and the motor. And all these 3 branches are composed of myelinated and unmyelinated A delta and C fibers. So these 2 branches merge together in the trigeminal ganglion, and then they move toward the brainstem. And they present in this complex anatomical structure here, which is consisting of 3 main components. So the blue one here is called chief sensory nucleus, which receives the touch and the proprioception signals from the head and the neck. The green one is called spinal nucleus, which receives the pain and the temperature signals from the head, face, and the cervical area. And the last one, which is the red one, is called the mesencephalic nucleus, which receives the proprioception from the jaw and the teeth. So all these 3 components together are called trigeminal cervical complex, TCC. In this slide, you are seeing in this diagram, and in the left side, you are seeing the very beginning part of the ascending pathway of the pain signal at the level of the dura. So this is the dura, the leptomeninge anatomy in details, starting from the dura mater, and then in the arachnoid, subarachnoid, and the pyometer. And you see that the blood vessels just moving in the dura layer and in the subarachnoid space. So this is the vasculature part of the anatomy of here. In terms of the neurology distribution, you'll see the autonomic system consisting of the sympathetic and the parasympathetic component, and you'll see the trigeminal distribution of the different branches of the trigeminal nerve here. So from these 3 systems, you will see different neurotransmitters are released. From the sympathetic nerve, we have release of the norepinephrine, ATP, and neuropeptide Y. And from the parasympathetic, you'll see release of PCAP, acetylcholine, and the VIP, which is a vasoactive intestinal peptide. And from the trigeminal nerve, we have release of CGRP, which is one of the most important neurotransmitters, have been explained as a background in the pathophysiology of the migraine. Another one is called PCAP and the substance P. So all these transmitters here in the subarachnoid space and the dura mater affect the function of the blood vessels. And more interestingly, we have another neighbor here, residence. It's called neuroimmune cells, including dendritic cells, mast cells, and macrophage. So in the beginning of this pathway, we have the blood vessels, we have different type of the neurons, different neurotransmitters. In addition, we have the immune cells. So in brief, the signal pathway in the migraine pathophysiology is starting from the trigeminal vascular pathway here, and then the pain signal transfer through the V1, V2, and V3, the three main branches of the trigeminal nerves, move through the trigeminal ganglia, then go to the brain stem and merge to an anatomical structure which is called trigeminal cervical complex. And from here, the pain signals start moving toward the upper part of the brain. So the main part of this area in the pons is tractus nucleus solitarius here. The other one is called salivatory nucleus, and the other one is called locus coeruleus. So all these three parts are responsible for the autonomic symptoms of the migraine. From here, the signals go forward toward the hypothalamus, and then they go to the thalamus, and lastly, they emerge to the different part of the cortex, which is called the frontal area, the sensory cortex, and the visual cortex. So this is the signal pathway starting from the trigeminal vascular pathway in the beginning and ends at the level of the cortex, which is called ascending pathway in the pathophysiology of the migraine. And in this picture, just you can think of treatment options, which is different nerve blocks we do for treatment of the migraine. We do SPG block here, we do occipital nerve block here, and we do the Botox to block different nerves here, transfer the pain signals from the beginning toward here, and then go to the cortex. So until now, we learned that migraine is a form of sensory processing disorder. But that's not the only part of the pathophysiology of the migraine. So in addition to the sensory dysfunction, we have autonomic dysfunction, we have cognitive issues, and we have affective disturbances as well. So it means that we have a multiple neural network dysfunction. But despite advance in the knowledge of pathophysiology of migraine over the last 3 decades, or maybe more than three decades, we don't know for sure how and where a single migraine attack starts anatomically and then how it resolves. So that's a lot of debate discussion during this different clinical stage of the migraines. So let's talk about the first clinical stage of the migraine, which is called premonitory or prodromal phase. In terms of clinical manifestations, this stage starts at least 3 days before a migraine attack. And many triggers are explained for this clinical part of migraine. Mainly it's called alteration in the hemostasis, which is a trigger for starting the premonitory phases. This is a pretty nice table which shows the premonitory symptoms during the migraine. And you see here different group of the symptoms. So the first group of symptoms during the premonitory phase is called neurocognitive symptoms. The second group is called hemostatic related symptoms. And the last one is the sensory related symptoms. In terms of neurocognition, the patient explains concentration issues, fatigue, memory issues, depression, and irritability. And in terms of hemostatic related symptoms, you will hear from the patients they complaining of the food craving, feeling thirsty, urinary frequency, constipation, frequent yawning, and sleep disturbances. And the last one is sensitivity to light, photophobia, phonophobia, osmophobia, feeling nauseous, and neck stiffness. So all these 3 symptoms are happening before the headache phase, which is called, once again, the premonitory or the prodromal phase. If you think of the symptoms, it addresses the chronobiologic pathway or involvement of the chronobiologic pathway during the first step of the migraine. And definitely, you know that the master regulator of the chronobiologic pathway in the brain is hypothalamus. So based on the studies, it shows that in episodic migraine, the anterior part of the hypothalamus is more involved. But during the chronic migraine, or when the episodic migraine turns into chronic migraine, the posterior part of the hypothalamus is more involved in migraineurs. So this diagram and this slide is showing the neurotransmitters involved this stage in more depth. So at the level of the hypothalamus, we have involvement of the orexin signaling pathway. And we have secretion of the orexin A and orexin B in the hypothalamus. And how does it work? So orexin A and B, they are responsible for these three things. The first thing is sleep-wake cycle. And here you can think of connection between sleep disorder and migraine, which is a very common coincidence in migraineurs. The second thing is the feeding issue. So the orexin A is responsible for feeding issues. And if you have increased level of orexin A during a migraine attack, probably the patient is complaining from the food craving. And the last one is autonomic function. So involvement of the hypothalamus through the orexin pathway is responsible for sleep issues, food craving, and autonomic dysfunction. Move on to the next anatomic place, which is midbrain here. And in midbrain, we have increased release of dopamine, which is responsible for increased yawning, which is one of the most common frequent symptoms during the premonitory phase. The next one is the pons. We have here the release of norepinephrine and different parts of the autonomic symptoms. We talked about these three components, TNC, salvatory nucleus, and locus coeruleus here, which are responsible for the autonomic symptoms during the premonitory phase. The next one is the medulla. By increase of the serotonin, is responsible for the part of symptoms during the premonitory phase. And the last one is the SPG ganglion, which is here, responsible for parasympathetic symptoms during the migraine pathway, the first clinical stage. So in brief, you will see here different anatomic sites and different neurotransmitters are involved during the first step of the migraine. So the hypothalamus by orexin here, the midbrain, which is dopamine here, medulla, 5-hydroxytryptamine here, and the last one is the SPG ganglion. But if you remember, in the table, I was talking about the cognitive symptoms as well. So it seems that we have involvement of the different part of the cortical area in addition to the brainstem, from the hypothalamus down to the medulla and the SPG ganglion, but we have involvement of the cortical area as well. In terms of the neurotransmitter, you will see here the dopamine, you see here norepinephrine, 5-hydroxytryptamine, but at different part of the brainstem throughout the cortex, you will see CGRP as well. I didn't talk about the CGRP here. So the unknown aspects of the first step of the migraine is, what is the role of CGRP? During the first part of the migraine, we don't know. The second question here is the role of the sympathetic part of the neurologic symptom here. We know that the stress is a trigger for migraine, and this is the location for release of norepinephrine and causing some sympathetic related symptom in migraine, but for sure we don't know clearly what is the role of norepinephrine during the first step of the migraine. And the other thing is the role of the cortical function during the first step of a migraine, cognitive issues. And very general question, we don't know what is the prevalence of the premonitory symptoms in migraineurs. Why? Because most of the part is unreported by the patients. The patient don't pay attention to these symptoms, or it's described as a non-specific symptom. So we don't know the prevalence of these symptoms. So these are the main unknown aspects of the first part of the migraine attack. The second part of migraine is called aura. So for many years, cortical spreading depression was explained as a universal acceptance or explanation as the pathophysiology of the migraine with aura, which is the second part of the migraine. And in terms of the neurophysiological correlation of CSD, in brief, cortical spreading depression and migraine, it was described in 1944. And what happens during the aura in terms of excitation, we have excitation of the neural cells and the glial cells, and this excitation followed by the prolonged suppression. And the suppression progress starting from the occipital area is proposed and then go toward the front part of the brain at a rate of 2 to 6 millimeter per minute. In addition to the neural excitation, we have vascular changes. So it starts with a hyperemia first, and then followed by oligemia. So we have vascular changes in addition to the neural changes. At the level of the cellular changes, we have accumulation of the potassium, influx of the sodium and calcium, release of glutamate, nitrate, serotonin, and the dopamine. And all these things is proposed from here, starting from the occipital area, and correlation with the EEG, you will see excitation here, and then followed by a prolonged suppression and propagation at the rate of 2 to 6 toward to the frontal part of the cortex. So you see here that the cortical spreading depression is primarily restricted to the cortex. And this part of the migraine explanation raises some interesting questions. So the first question is retinal migraine, and why I'm talking about the retinal migraine. Because retinal migraine is a type of migraine with aura. So it makes sense we are talking about the cortical spreading depression and retinal migraine. So the question here is cortical spreading depression is a likely cause of the retinal migraine? If you look at the criteria of the retinal migraine based on the ICHD, we have a patient present with the monocular visual changes, including positive symptoms like the scintillation or negative symptoms like the blindness, and the symptoms meet these three criteria. So the criteria for migraine with aura, they should meet the criteria for migraine with aura. These symptoms are monocular, so they're present in one eye, and they are lasting for 5 and 60 minutes, or after 60 minutes, they're followed by the headache, and there is no better explanation for these symptoms. So the question is here, is CSD is a likely cause for retinal migraine? To address this question, I will explain to a study here. The first study is an animal study. The topic is involvement of CGRP receptors in retinal spreading depression instead of cortical spreading depression. So the research topic here, or the research question during this animal study, was whether retinal spreading depression, or RSD in brief, is present in the retinal tissue. And then the second question during this study was, what is the role of CGRP receptors in the retinal migraine? In this graph, you will see here that they show the different proteins expressed in the retinal sample of the cheek, which is the animal study here. And you will see here a big or significant band of a protein, which is called CRL, which is an important part of the CGRP receptor. So it means that the CGRP receptor is expressed in the retinal tissue. During the second part of the study, they excited the retinal sample with infusion of the potassium, and then they mapped the electrophysiology activity in the retinal tissue, which was excited by the potassium infusion. So this part of the brain is excited, this part of the retina is normal. And this red box is the area of interest. So you will see here in the part of the excited part of the retina, you will see here increased activity of the electrophysiologic activity. And more interesting, when they added the CGRP blockers in this tissue sample, you will see here that we have decreased electrophysiological activity, and they starting the wearing of the CGRP blockers. And this is the control group. So it means that we have CGRP receptors in the retinal tissue, and when we add the CGRP blockers on the sample, it shows that we have decreased electrophysical activity. So they concluded that migraine in retina might be different from aura in the cortex. The second study I'm going to talk about to address the retinal spreading depression instead of cortical spreading depression is a study which is published just recently in the Journal of the Headache. That is a very interesting research. And the research question here is to investigate the effect of the migraine attack on the retinal vasculature and the retinal structure using a retinal scanner, which is called optical coherence tomography angiography, or OCTA. And definitely we know that the visual symptoms during the migraine with aura originates from the visual cortex. But the question here is it possible that the eye could play a role in addition to the cortex causing the retinal symptoms? Or in addition to the cortical spreading depression, which is starting from the cortical area or the occipital area, do we have the same phenomena in the retina, which is called retinal spreading depression? So to address this question, they had 3 groups in their study: migraine with aura, migraine without aura, and the control group. And they did retinal scans on both eyes during the interictal and ictal phases for migraineurs, and they did 2 scans at different times for the control group. And this is a picture how it looks like from a retinal scanner. So this is the fovea. This is the central part of the macula, which is no vascular area here. And this is the vascular part of the macula. And this is a normal picture of the retinal scanner during this study. So the variables they measured during this study based on the retinal scanner was 2 things. The first thing was called VFI, which is the vascular flow. And the second variant they measured during this study is called foveal avascular zone, which is FAZ. So they measured these 2 parameters in these 3 groups based on the retinal scan images. And this is the results. During the interictal states in this map, you see 3 groups here. So the middle one is called migraine with aura, migraine without aura, and the control group. And you will see here that the vascular area during the interictal states is lesser comparing to the migraine with aura. But if you combine the migraineurs patients with the headache control group, statistically, there is no significant difference in terms of vascular parameters between the migraineurs and non-migraineurs. More interestingly, this is the picture of the retinal scans during the interictal states. So this is the avascular area in migraine without aura, avascular area in migraine without aura. This is with aura and without aura. And you will see more larger green area here, smaller one here, and the last one, which is the control group here. And once again, if you rank the size of the green area, the larger one is for migraine with aura, the smaller one is for control, and in between we have migraine without aura. So it means that we have decreased vascular changes in migraine with aura. And once again, during the interictal state, there was no significant difference between these 3 groups biostatistically. More interestingly, when you look at the images and the changes during the ictal state and compare the results of the ictal state with the interictal states, this is the map. This is the migraine with aura, this is migraine without aura, and this is the control group. And here you will see a significant changes between the migraineurs and the control group. So we have a significantly reduced vascular changes in migraine with aura first, and then migraine without aura. And when you compare these two groups with the non-migraineurs, that is a big, big difference. And this is the interpretation of the results. So definitely we have a reduced vascular changes in migraineurs during the interictal and ictal state, but more significantly during the ictal states. And it means we have vascular changes, the same vascular changes we explained in the cortical area, the same vascular changes in the retinal area, which is in favor of the theory that we have probably retinal spreading depression in addition to the cortical spreading depression during a migraine with aura, especially in retinal migraine. But what is the unknown aspect during this part of the migraine? Once again, retinal spreading depression is a real phenomenon in migraine with aura. For sure, we don't know for now. And the other part is vascular changes biomarkers using a retinal scanner could be a biomarker for assessment of the migraine, could be. Retinal scanner is a pretty easy and user-friendly scanner, and we can use this scanner to assess the migraineurs during the migraine attack. Another interesting question for me, in addition to the retinal migraine, is the brainstem with aura. So the question for me here is migraine with aura, with brainstem aura, most part of the symptom is originating from the brainstem. So you see here the diagnostic criteria for brainstem with aura. So the symptoms should meet the criteria for migraine with aura. Once again, it makes sense. We are talking about the CST. The symptoms with brainstem aura is dysarthria, vertigo, tinnitus, hyperacusis, diplopia, ataxia, decreased level of consciousness, and there should be no motor and the retinal symptoms. If you look at these symptoms are coming from the brainstem. So the question here is how we can explain the cortical spreading depression causing the brainstem symptoms. For sure, we don't know. But based on the study, they found that peripheral vestibular system probably could have contribution to the brainstem with aura. Why? Because if you look at the symptom, vertigo, tinnitus, or hyperacusis, probably they are originating from the peripheral vestibular system. This is an animal study I found just to address the question, what is the connection between the CST and the brainstem? Definitely, this animal study doesn't address my question directly, but it shows some connection between the brainstem area and the cortical spreading depression. So this is the mouse model of the migraine, the ascending pathway, starting from the trigeminal ganglia, TCC here, and then go up to the cortex. And the question here is the role of the locus coeruleus, which is the anatomic part of the autonomic system in the brainstem during the migraine. So this is the awake state, and this is the sleep state. During the awake state, we need the autonomic symptom, specifically the sympathetic symptom, which is sympathetic part of the or nervous system, which is located in the locus coeruleus, a part of the brainstem. But during the sleep time, we don't need that. So there's a reduced function of the sympathetic symptom during the sleep state. But if you block the TCC complex or you block the LC, which is the locus coeruleus here and here, which is mimicking the sleep condition of the migraine, this block results in the induction of the cortical spreading depression. So this part of the study explains probably sleep-induced migraine, which is called hypnic headache, and some patients are suffering from migraine during the sleep. So this animal study explained the connection between the brainstem and the cortical spreading depression, but once again, it doesn't address my question, what is the reason for brainstem with aura during the migraine with aura coming from the cortex? We don't know. The next part of the headache, the migraine, is the pain in the head, which is the headache. So we talked about the trigeminal vascular pathway here, starting from here, and then go through the three branches here, through the trigeminal ganglion, the brainstem, which is the TCC, and then go on to the cortex. So we know that ascending pain signal starting from here, here, and then here. So the question here, what is the reason for triggering of the first part of this signal pathway, which is the trigeminal vascular pathway? One of the proposed mechanism is the cortical spreading depression. That's interesting because CSD is an explanation for the aura. But based on the investigation, it shows that cortical spreading depression could trigger the trigeminal vascular pathway at the same time causing the headache, which is the third part of the migraine pathway. And what about the other triggers for TVP? The other triggers is probably any trigger during the premonitory phase. And why we are talking about these triggers? Because in 11% of patients with migraine, we have headache and aura at the same time. So it means that any triggers during the premonitory phase, which is the first part of the migraine, it triggers the TVP and it triggers the CST at the same time. So we have aura and we have headache, which is 11% of the migraineurs. So until now, we know that the triggers for the TVP is the CST or any triggers from the premonitory phase. But what about the other part of the triggers in the beginning part of the signaling pathway during the third part of the migraine? For sure, we don't know. This is more details in the beginning of the process. And once again, back to the first part of my presentation. If you remember, we had dura and we had the vasculature component here, and we have the nervous system here. So what happened during the headache? In general, it's called neurogenic inflammation. So we have triggers by neurons. They affect the vascular function here. They release some neurotransmitters here. It results in a phenomena which is called neurogenic inflammation. And we have three main components during this neurogenic inflammation. The first thing is increased capillary permeability, which is causing plasma protein extravasation here. And this slide, you will see the normal part, the normal situation of the dural vessels in an animal study. And you see here the inflamed blood vessels during the headache. Just last week, we had a patient with Dr. Rastogi during my inpatient service, and interestingly, we saw an animal example and a human example of these inflamed vessels. So this is plasma protein extravasation. The second part of this neurogenic inflammation is arterial vasodilation. So this is a patient, 12 years old, presented to our neurology department with aura unilateral headache on the right side and the motor aura in the left side. This is the SWOS sequences of the brain MRI. And if you look at the blood vessels here and compare the blood vessels on the left side, right side with the left side, you will see an increased dilation, blood vessels in the right side, ipsilateral to the headache, which is very, very interesting finding in this patient. And in this image was capturing the blood vessel changes during the acute phase of the headache. So the third part of the neurogenic inflammation is activation of the immune cells. So based on this explanation, which is called neurogenic inflammation, you can think of steroid, NSAIDs, and the ergotamines as treatment options here to reduce the neurogenic inflammation. And the newer generation of treatment here is triptans, which is acting through the serotonin 1B and D receptors, and newer medication, which is called lasmitidone, acting through the serotonin 5-HT1F receptor, and we have CGRP blockers here. So all these treatment options works from here through the different part of the signaling pathway I showed you over the past slides. Just a heads up, in terms of the serotonin receptors, we have the nerve ending here at the dural level, and we have the blood vessels here. If you look at the serotonin 1B and 1D receptor, we have 1D on the nerve end, and we have 1B here on the blood vessels. So if we use the triptans, we are blocking the nerves and we are constricting the blood vessels. But about the new generation of the rescue medication for migraine, which is called lasmitidone, it works through the 1F receptor, which is here again on the nerve ending, but not on the blood vessels. So it makes sense that when we use the lasmitidone, we don't have any blood constriction as a side effects of these new medications. Let's talk about the immune cells and their role during the migraine attack. So we know that they are present at the dural level, and they release some neurotransmitter such as the substance P, and they play some roles to trigger the meningeal nociceptions through release of these neurotransmitters. But what is the main roles of these immune cells during the migraine attack overall? There is no enough data to explain the role of these immune cells during the migraine attack. But just we can think of relationship between the allergy and asthma and migraine as coincidence. And we see lots of patients, they have migraine and they have coincidental allergy-related symptoms at the same time. And once again, you can think of steroid and NSAIDs as treatment options here to reduce the immune function cells during the migraine attack. And the last part of the migraine attack is called post-stromal. So the various symptoms has been explained during this stage, including fatigue, sensitive to light, sound, hypersensitivity, concentration issues, mood issues, neck stiffness. So pretty similar and non-specific to the headache phase and the premonitory phase. So why these symptoms are still there after the headache is gone? There is no enough data to explain this part of the migraine. And more interesting, based on the imaging data, functional imaging data, they show that we have still activation, neurologically activation on the level of the eyes and some part of the brain, which is hypothalamus, pons, TCC complex, 3 days after the headache is gone. So some part of the brain is still active after the headache is gone. Why? We don't know. So that may explain this part of the symptoms continue after the headache is gone. But definitely we need more study to explain these symptoms. So the challenge for this part of the study is if a patient comes to our clinic, we definitely treat the migraine attack. So this treatment influences the clinical finding and the imaging finding during the post-stromal phase. So probably we will have some bias, and that's a challenge to study this, which is the last stage of the migraine. And the last challenge of mine for complexity of the migraine pathophysiology is unilateral versus bilateral changes. So anatomically, we know that we have a decussation of neural elements at the level of the brainstem, and when all these neurologic inflammation and neurotransmitter release, and these neurology changes happening in the brain. So why the patient present with unilateral headache, and we know we have decussation? Again, there is no clear explanation why we have unilateral symptoms, despite of the presence of the decussation in the brain. So in conclusion, we learned that migraine attack includes multiple stages consisting of different symptoms, and we can map these changes to the altered brain function. And we talked about different neurotransmitter released during this complex neurologic disorder. We have different clinical stages for migraine, and they have overlap in terms of time onset. We talked about the retinal spreading depression instead of cortical spreading depression. Is it real? Probably. And the same thing about the brainstem with aura. There is no clear explanation for that. And the other thing is cortical spreading depression as a trigger for migraine, for headache. Is it real? We don't know. Does it function through the central part of the brain and peripherally? Both of them, probably, but again, we need more data. And lastly, why the patient is still suffering from some symptoms after the headache is gone during the remaining of the attack, which is post-traumatic phase. We don't know. And this is the future perspective for migraine pathophysiology or in general migraine. So definitely migraine warrants more attention based on the incidents we explained in the beginning of my lecture here. And we need more headache providers, definitely. More research is warranted to shed a light on the complexity of the migraine pathophysiology. And more interestingly, CGRP blockers can be used as first-line treatment for migraine attack, like a rescue treatment and prevention treatment as well. Why? For now, we are using the traditional medication, and we fail two traditional medication, then we think of the CGRP blockers. And this is a very recently consensus published in the Headache Journal, and they are talking about using the CGRP blockers as the first-line preventive treatment in migraine without requirement failure of two traditional medication. And definitely we need more medication to fix the headache, because we know that the current medication are not the whole solution for migraine. Probably other neurotransmitter blockers, substance P blockers or PACAP blockers, things like that. So let's talk about a few fun slides to reduce the headache if you are interested in following the movies. For this year, Oppenheimer, one of the best movies, was selected by the Oscar Academy as the best movie of the 2023. So you can put it in your waiting list if you are interested in watching movies. And this is some nice pictures. This is a rainy day. It's not North Africa or any other part of the world. This is North Scottsdale from my camera, and so double rainbow. And we had the Persian New Year, last one just a few weeks ago. So it's called Nowruz, and we have half seen here. So different things, 7 things, starting from the letter S. And we had the social and the scientific meeting of the Minds for Migraine, which is a non-profit organization supporting the migraineurs and the headache providers. And we have both events of the Minds for Migraine in Phoenix last month, and I attended both of them. And this is the social event of the Minds for Migraine, the small group of the PCH. At the end, I don't like to miss this slide, which is my attending physician. I would like to express my deepest appreciation for their teaching over the last year. And thank you so much for your attention. I will be happy to take any questions you have.
Hi, can you hear me okay?
Yes, I can.
Okay. Thank you for that talk. That was an excellent talk, and one on a topic which is near and dear to my heart. So thank you for choosing migraine pathophysiology. My question, though, is actually on epidemiology. At the very beginning of the talk, you showed a very interesting slide showing the world map with different incidences of headache around the world. And there seems to be quite a discrepancy in different parts of the world. Do you have any opinion or any explanation for why incidence rates of migraine are so disparate in different areas of the world?
So just based on the methodology by explaining this paper, they explain this data across different countries with different STI. And again, if you back to the slide, you will see the most incidence at the age of 10 to 14. And if you go up to the upper age, the incidence of the migraine decrease. And that's the case for high and low STI countries. But again, to address your question, there is no specific data was presented in this paper. Was that your question, Dr. Lee?
Yes, it was. Thank you.
My pleasure. Any other question?
There's a question from Dr. Kruger in the chat.
No. Okay. It was intrigued by MRI that showed dilated red blood vessels in one hemisphere. Do you think the MRI images could guide our patient managing more often? That's an interesting question, Dr. Kruer. Just after I saw these images, I started searching on the Google to look at other papers published on this data, because most of the data we have on the inflamed blood vessels at the dural level or in the brain is coming from the animal study. So for now, I do not have honestly any idea specifically on the human brain and what's going on regarding the blood vessel changes in the human brain. So this is the first image I got from one of my patients, and just after that, I started searching on this topic. So hopefully, to address your question, we will have another paper published by Dr. Stogian or group to address this question. For now, I have no specific idea. All right, so I'm not running behind the time. I'm lucky. If there is no any questions, so hopefully you enjoy and have a wonderful day.
Thank you, Dr. Tavasoli.
My pleasure.